Thank you so much for that introduction, Alicia. Can everyone see me on the slides? Or more importantly, the slides, I guess. All right, great. Thank you. It's so good to be here, and it is an absolute honor for me to share this virtual panel of speakers with Dr. Henry Jones. So today I'm going to be speaking about challenges and solutions, especially when it comes to treating opioid use disorder in adolescents. I just wanted to highlight some of the talking points or takeaways that I took from Dr. Jones's presentation earlier today. One was her slide stating that substance use disorders are pediatric disorders, and we start treatment. We can start treatment when kids are still kids. The other aspects of that talk was also the use of medications. Apart from pregnant patients, adolescents are also a vulnerable population in which medications are not used as often as they should be. So today, what I'm going to focus on is really talking about how we have built up the addiction program at Children's National over the last 2 years, which kind of coincided with the increase in opioid use disorder that we started seeing in adolescents. I don't have any disclosures. Learning objectives. We're going to describe the challenges faced by adolescents in the district with opioid use disorder to enter treatment. Understand the system-based barriers faced by providers in delivering evidence-based care. And finally, identify solutions to address gaps in care. Now, this is one of those talks where at the end of this presentation, if you leave with more questions than you came in with, that would be a good thing, because what I can show to you in the next 35, 40 minutes or so is that there's a lot of unanswered questions, and we're trying to adapt every day to get ahead of this situation. So I'll start off with the case. So we're going to talk about one of the first patients who was admitted to the hospital at Children's National. This was January of 2022, admitted for opioid use disorder specifically. So she was dropped off by family members in the emergency room for safety and management of opioid use and opioid withdrawal. There's no previous psychiatric history, so she was admitted to our hospital medicine floor. And she reported smoking M30 pills, up to 10 per day for the last 6 months. And at that time, our urine drug screen was negative for opioids, but positive for THC and positive for cocaine. If you're unfamiliar with the M30 pills, I would say 99% of our patients in the DMV region use M30 pills as their primary source of fentanyl and opioids. And the preferred method so far has been smoking the pills. What they mean by that is it's usually a foil is involved, the pills are heated up, and the fumes are inhaled. Crushing and using these pills through their nose or snorting them is also another popular method, though not as popular as smoking. Finally, the urine drug screen that we send out, because our standard opioid panel does not include fentanyl, the urine drug screen that was sent out was positive for fentanyl, but this took 3 to 4 days at that time for the test to be sent out and the results to come back. So before we dive in further into the case, I wanted to kind of show you some data on what exactly is going on. So this is from the SAMHSA's key substance use and mental health indicators in the United States. I specifically wanted to highlight the data from the National Substance Use and Mental Health data set. So in this data set for ages 12 to 17, when they looked at the past year OUD diagnosis, the number of kids in 2023 was around 316,000. In 2022, it was about 265,000. And if we go all the way back to the 2020s, 2019, it used to be less than 100,000. So we can say that the overall prevalence of opioid use disorder has increased in this population. And the challenge has been that a lot of data highlights has been around opioid overdose deaths. And people often kind of put this in the back burner regarding kids with opioid use disorder needing treatment. So a lot of efforts have gone into preventing overdose deaths, and less effort has gone into actually figuring out ways to treat kids who meet diagnostic criteria for opioid use disorder. Now, so this is national level. What does this look like for us in the pediatric hospital, especially in the district, is that we've had an increase in the number of kids presenting to the hospital for opioid related reasons, not necessarily just following an overdose, but even outside of an overdose. So this will look like they're presenting in opioid withdrawal, asking for help. They might present with severe malnutrition. Weight loss is very common in this population. It can be upwards of 20 to 30 pounds in a 6-month period. It can be due to infectious diseases. Some of them are sexually transmitted diseases, but we've also had other kinds of infections presenting in this population that we don't know what role their substance use plays in them getting that infection. And then there's concerns like being sexually trafficked or sexual abuse, violence, gunshot wounds, etc. So at any given time, we do have multiple kids admitted to the hospital, and we're trying to figure out how to address the opioid use disorder, but also the co-occurring illnesses for which they have been admitted. So for this patient in 2022, when she was first admitted, there was no protocol in place to manage opioid withdrawal. And so one of the first things that they did was to create a protocol. So we had an interdisciplinary team which comprised of psychiatry, adolescent medicine, pharmacy, nurse educators, and our house staff, our pediatric residents. And we had to create protocols to manage withdrawal symptoms. And because we were building it out for opioids, we also built it out for nicotine, cannabis, alcohol, so that anytime a kid is admitted now to manage, for withdrawal management or complication, we have systems in place to help them. There are simple things like the COWS score, not being familiar with the nurses in the pediatric hospital. And it was not built into our electronic medical record. So a lot of work went into educating our staff on using the tools required to treat opioid withdrawal and also building it into EMR. And these things unfortunately took time. So it was a while before we were able to build it in the EMR, but we still used paper charts and were meticulously documenting them. More importantly, at that time, buprenorphine, naloxone, and naltrexone were not medications we had readily available in our formulary. So for this specific patient, we had to order to an outside pharmacy, have family pick it up, bring it to the hospital, and then figure out how to dose them appropriately. And I can share that since then, we have been able to add these medications to the formulary so that now kids coming in, if they need the medications, it's on formulary and there's no lag time between trying to procure it from an external pharmacy. And finally, lack of testing capacity for urine drug screen to detect fentanyl. So it used to take 2 or 3 days for us to get the results back, which made it challenging because at the first point of entry into the emergency room, when kids were presenting in withdrawal, if their opioid screen was negative, that often confused the diagnostic picture for the emergency medicine provider to make decisions. And since then, we've also implemented point of care urine drug screens to aid decision making in the clinic. So for this patient, we ordered the buprenorphine naloxone, and we were able to successfully start it and build in protocols into the in the systems that we have at the hospital, and the patient was successfully discharged from hospital. Now, the patient was actively seeking residential level of care and was willing to go voluntarily, but unfortunately, there was only one residential program in the entire region, and they wouldn't take Medicaid. And this particular state Medicaid would not work with out-of-state residential programs to pay for services. So this really took residential level of care off the table for us. And another factor that we found out was that if we do start medications inpatient for kids, we don't always have outpatient clinics willing to prescribe buprenorphine naloxone specifically for patients younger than 18 at that time. And finally, this particular patient was 16, did not want to return to school. Since she knew that return to school meant return to fentanyl use, and she wasn't willing to take that risk. So um, this was the situation. This was January 2022 when we had to figure out, what does treatment look like for a 15-year-old who is struggling with opioid use disorder from their fentanyl use. So in terms of providing care, we were able to we had a clinic that was just starting at that time to help kids with addiction, but we didn't have any psychosocial supports at that time, including individual therapy or case management services. And the lack of residential services really meant that we had to collaborate actively with community members. And in this particular case, we were able to get an assertive community care approach where the patient was able to go to groups, but also had a therapist who would come home, and we were able to continue MOUD at our children's addiction clinic. And apart from the children's addiction clinic at that time, there were other clinics in the region who are also starting to see an increase in number of adolescents presenting with opioid use disorder and figuring out their own pathways to help these kids. And one such program was Mary Center. And we built close relationship with Dr. Dan Smith at Mary Center to figure out care for these kids. And finally, school as a high-risk zone for return to use. Now, this has been a significant challenge for us because when we think of recovery in adolescents, school plays a big role because they need to successfully complete a high school diploma or a GED to have a good developmental trajectory. That's a big protective factor for them. So we were working to identify recovery-oriented programs for kids to finish a high school diploma or a GED. And what we have noticed in the district, at least, is that there are several charter schools which specifically help kids learn skills that would help them go on to obtain jobs. One example where we've had some patients have good success would be Youth Build Charter Academy. They essentially pay the kids to come to school, get them onto internship programs, and help them build resumes, complete their diploma or GED, and go on to get jobs. So I just want to talk a little bit about the addiction program at Children's. This was what we started in January of 2022 under the Division of Psychiatry. So the basic service that we offer, it is ASAM level 1, and we are able to offer medication management for substance use disorders and co-occurring mental health disorders, right? But treatment for substance use and opioid use disorder specifically often goes beyond just medication management. So our goal is always to figure out how to build out our services. At the time of establishing this clinic, we only had a full physician available 0.6 FTE. Which happens to be me. And we had to figure out ways in which we can expand services within that limited time frame. And apart from taking over care, we were also offering consultation for substance use disorders and co-occurring disorders in children to pediatricians and other primary care providers in the region. And as we started setting up, we also noticed this increase in the number of kids presenting with OUD, and we really had to figure out our workflow, especially to decrease barriers in treatment entry. And this is something that we're still working on. Any questions so far about how we started off with setting up the clinic?
Is there any issue?
Alicia, I couldn't hear your question. I don't see any questions in the Q&A.
No, sorry. I was just making sure everything was going okay.
Okay. Yes, if chat is not working, please do put your questions in the Q&A. So we had a start in terms of, we had our first patient and we were trying to figure out how to help this child as a pediatric hospital system. And now with the increase in volume, we were identifying multiple other challenges. And I'll go over another case to kind of highlight those examples. So this is a 17-year-old male who presented to the emergency room seeking help for fentanyl use. At the time of presentation, though, the patient was not in withdrawal. Last use was a few hours ago and was agreeable to any recommendation from healthcare providers in terms of treatment. There was no other co-occurring illnesses that made the physician at that time concerned, apart from opioid use disorder that the patient reported, and the patient was discharged with a referral to the addiction program. The patient never made it to the intake. So the challenge has always been when we don't admit patients and we're discharging them, how do we successfully connect them with outpatient level of care? Because the window of opportunity when it comes to adolescents is very small. We really need to be providing them help at the time that they're asking for help. Any postponement of initiation of treatment then means that it's hard to further engage them in care until at the time that they feel ready again, which we don't know when that might be. So the question is also admission determination, inpatient versus outpatient. When we do have patients presenting to our emergency room, pretty much every single pediatrician that I've met wants to admit all these kids. But unfortunately, the pediatric bed availability is often a low resource and it's not always available. And then there's other systemic barriers in place, like insurance payment for services. Now, ASAM does provide, the American Society of Addiction Medicine does provide guidelines on how to assess for a level of care, but we do find that many a times a lot of our patients score low on the dimensions required for inpatient level of care, especially because at the time that they're presenting to ED on dimension 1, which assesses severity of the withdrawal symptoms, they might not often be there, or they might not have used opioids or fentanyl long enough to have had any significant periods of withdrawal that would inform us to adequately use the ASAM tool. So we had to create our own guidelines and criteria to stratify risk. And this is still a work in progress because apart from us saying these are reasons we're going to be helping kids with an inpatient admission, there are other factors to consider here. And then there's the challenge of the lack of treatment initiation at point of first contact. And for a majority of our patients, this may be either the emergency room or their primary care pediatrician's office. And what we need to think about is medications for opioid use disorder initiation in the emergency room and an opportunity to distribute nasal naloxone in the emergency room. There are significant challenges in thinking about buprenorphine initiation, especially in the emergency room. This is more commonly done in adult or healthcare facilities serving patients over the age of 18, but this is unheard of in a pediatric emergency room. But we were able to try this as in very specific circumstances, and we, I believe, are the first pediatric hospital in the country to be able to do this. And we recently published our experience with initiating buprenorphine treatment for kids in a pediatric emergency department. And finally, improving engagement and treatment retention. So this is still a challenge that we are trying to figure out because many a times, most people who are attending this talk know opioid use disorder, like all substance use disorder, is a chronic illness that starts in children. And we want to, and it has its ups and downs, and we want to be able to successfully engage patients in treatment. Now, we know that our peer recovery support specialists are doing an incredible job in helping facilitate treatment in patients who are older than 18. But what does the role of a peer recovery support specialist look like in the pediatric emergency room? And how do we successfully utilize their help? So this is a role that we are currently exploring in terms of implementation in the emergency room. And we are in the process of hiring people. So, and one of the shout outs is if you are a peer who's listening to this talk and interested in taking on this role, please do visit our career website. You will find positions for this role posted there. So I'm going to stop here again for questions.
Once again, you can put your questions in the chat, or you can go ahead and raise your hand within the chat function. does look like we have someone who raised their hand. I'm going to go ahead and allow you to speak. That's the same. Okay, does not look like we have any questions at the moment.
So there's a good question here. What barriers do you foresee with implementing the peer program at Children's? I'm going to go ahead and answer that question. So in terms of barriers, it's often comes down to training. So most of the peer certification program that we could find is focused towards the role of peers in working with adults. And we need to figure out what is the scope of training that peers are going to require to work with um, patients younger than 18. And another barrier, and that's education piece. And also we have to train them to work with families because families play a really important role in recovery for many of these kids and understanding the developmental trajectory of kids in itself. So the barriers at this point mostly comes down to the kind of training that we would need to provide a peer to work with adolescents. So other um, newer areas of knowledge might be things like how to use social media successfully and how kids use social media in terms of access to substances, the role of CFSA or Child Protective Services, and how do we include them? What is the mandated reporting requirements? So the barrier at this point is how do we adequately train peers? And we are addressing that by providing specific didactics or focused curriculum to help our peers work successfully with kids. All right. I do have a short presentation, so there'll be a lot of time for Q&A in the end. So the third case that we have is a 15-year-old patient presenting to emergency room seeking help for fentanyl use. So this was a little later in the year. By this time, we had the protocols in place. We had medications on formulary. And this patient was successfully discharged and referred to the addiction program. The patient successfully initiated medications for opioid use disorder, successfully engaged in psychosocial services, and this patient did have access to a recovery program in their high school. Now, within a month, the patient stopped going to therapy and was discharged from recovery high school program due to concerns of ongoing use and also being disruptive in the mood. One of the key challenges here is what the patient's mom told us. Essentially, as many of you know, adherence with taking buprenorphine naloxone, especially the sublingual form, is challenging for most adults. Often the taste of it, the nausea, and other side effects they may experience. And most adolescents are less tolerant to distress, especially when it comes from a medication that they have to take every day. In this particular case, I just quoted mom here. The mom told me that they have to strap this child to the chair every day with the sibling and put the medicine under her tongue and wait 5 minutes for it to dissolve before they will let her go. And that's the only way mom felt that they could keep her safe. Now, this challenge is kind of talks about the system not being built to accommodate the ups and downs of addiction. So we can't, one of the things that we emphasize in our addiction program, at least, is we don't discharge patients, right? Like we're going to meet them wherever they are and try to help them from that point onwards. And the systems, though not all around us, are not often built to accommodate the ups and downs of addiction because many of the programs that do offer psychosocial services, unfortunately, often then revert to discharging patients if they have returned to use, which has been challenging. So we need to find ways to adapt to the needs of this population. Especially with kids, the challenge is this is one of the first times that they are interacting with the healthcare system, and we want to make sure that we are providing care in a non-stigmatizing manner. So even when kids have returned to use, our message has always been, we are here, our doors are open, we will find ways to help you now or when you're ready for help. medication adherence in adolescents and young adults, and this was also highlighted by Dr. Jones in our previous talk, has always been a challenge. And we wanted to understand the role of extended release injections in those cases. And the challenge is when we think of medications for opioid use disorder, buprenorphine is, as in its sublingual and oral form, is approved ages 16 and above, but injection use is considered off-label. And the question then becomes, what if the patient does not want to engage in psychosocial services or therapy? We do not use that as reasons to discontinue treatment with medications for opioid use disorder. We do continue medications at that time. And the goal has always been, if you don't want to engage in treatment of any kind, prioritize safety. And
Okay, that Midas guy was way too slow. He couldn't even get past the receptionist.
excellent. And then, like mentioned about treatment, it's going to be prioritize safety consistently. And this often means prescribing nasal naloxone for our patients. So I do see a question. I will get to the question about dose soon. So I wanted to kind of highlight that this is the way that we are trying to slowly build our internal systems at Children's National, but also how we think about partnership with our community collaborators. So this is data that we were able to pull for a brief report that we are working on. So this is still, it's under peer review, so I wouldn't cite this paper just yet. And if you do find out any errors, please do let me know. So we kind of took a sample of kids. This was in a 10-month period in 2023. We specifically looked at kids presenting to the addiction clinic with opioid use disorder that was related to their fentanyl use. And we had a total of about 24 patients in that 10-month period that we treated. What we wanted to highlight was that all these kids are presenting voluntarily for treatment. They are saying, I need help, and they came to the first appointment. And in terms of who they are, demographic information, we had more males than females. Majority of them identified their race and ethnicity as Hispanic or Latinx. And in terms of referrals, we had referrals from primary care pediatricians and the emergency room kind of even out, but many of them also came following hospital admission for overdose or withdrawal with complications. And 100% of them had family involvement at intake, which is not a requirement, by the way, but it is always helpful when we do have families play this important role. When we look at who these kids are in terms of their substance use, their age at first use of opioids, which for most of them was fentanyl, was about when they're 15 years old. And about 1/3 of them, that's 8 of them, had experienced overdose. And it's hard for us to tell whether this number is high or not because there's not been a consensus on the rates of overdose being high among kids and with opioid use disorder because their opioid tolerance is quite different compared to kids who use other drugs and are then exposed to opioids. In terms of opioid use method, like we mentioned in the beginning, smoking seems to be the most preferred method. And for many of these kids, the age at first use of any substance, which is usually cannabis or nicotine, was when they were 13. And if you see the standard deviation, it's 1.6. So we also had kids who started using when they were 11. And I've since then had kids who started using cannabis or nicotine since they were 8 or 9. And cannabis, nicotine, and alcohol seems to be the most common substances that they reported using. But interestingly, the psychedelic use rates was high, or we thought this was high because half of them had reported using psilocybin or LSD in the last 1 year. And cocaine use rates were lower in this population. Now, when we look at overall, so the way the appointment goes is I usually have 1 hour to 2 hours for the first intake appointment. And we have an informing meeting where we discuss with them what an addiction means if they meet criteria. And then we offer them the different medications that are available. We prescribe buprenorphine, naloxone, and naltrexone in the clinic. And if they say they want methadone, we have resources for referrals in the community for that to the local OTPs. And but most of the patients, as you can imagine, choose either buprenorphine or naltrexone. So most of our patients did choose buprenorphine naloxone over naltrexone because it was their thought that they couldn't go the required 7-day period of abstinence from all opioids before starting naltrexone. In spite of this, we did have 5 patients who started out using naltrexone instead of buprenorphine naloxone. Now we looked at these patients' engagement with psychosocial services. At the time of intake, we were only able to refer or get 6 of them successfully connected. And when we looked at follow-up data, of the 24 patients who were seen at intake, 19 of them were still engaged at the clinic at 1 month. 14 of them were engaged at 3 months. And the rates doesn't really seem to change based on the medication choice. If you look at it here, but again, this is all descriptive data that we can't really come to any conclusions based on this. But I just wanted to provide everyone with like what this looks like in the front lines this was 2023, kids in 2023. So I'm going to pause here and see if there's a couple of questions. So in terms of, this is a good time to answer the question about for adolescents using fentanyl. The first question is, for adolescents using fentanyl, what are your thoughts on 8 milligram of buprenorphine? I've heard discussions about increasing the dosage for adults, but not sure if that would change for the adolescent population. So in terms how we approach this is the dose is whatever the patient requires, right? If we look at the approved dosage, we can give up to 24 milligrams. And in adults, I have many patients who are on up to 32 milligram doses. But with adolescents, just overall in our region, we are finding out that most patients seem to be doing well, anywhere between 8 milligrams to 16 milligrams. A few of them require 24 milligrams. So it really comes down to, does the dose really help the patient with all the withdrawal symptoms, and if it adequately addresses their cravings? One anecdotal piece of information I don't mind sharing is that a lot of the patients, when I know that they might report their cravings are good, they don't have any withdrawal symptoms, but if that is not the case, their cannabis use tends to go up. So we tend to keep track of their cannabis use closely to also assess for whether the buprenorphine is helping or not. How much emphasis is placed on behavioral change and behavioral therapy? Are they at risk for violence? So we do have patients who, there's a lot of emphasis on behavioral therapies and change in behavior. But then our clinic is primarily set up to provide medications, and we need to really connect them at this point to external agencies for behavioral therapy. And the patients might not want to engage, which is what we are finding out when we do make referrals. And even if they successfully connect with therapy, many of these kids don't want to sit in a group with other kids, or they don't think that it's helping them. So we don't really say, we're not going to treat you if you don't engage in behavioral therapy. Because we know that being on a medication for opioid use disorder is more likely to help them stay safe and decrease chances of subsequent overdose. Are they at risk for violence was the second part of that question. Many of them are at risk for violence, or they've been exposed to violence, or there's gang involvement, and but that is, I can't tell you with an exact percentage, but the more sicker, the more serious patients that I've seen, there's always an aspect of violence there. And then the next question is, how do you approach treatment planning for younger patients with co-occurring mental health disorders and substance abuse issues? So in terms of, so we don't do sequential treatment. I don't say we have to treat one and then the other. We try to integrate treatment for both at the same time to the best of our abilities. And so it's like, if oftentimes there's a diagnostic dilemma in terms of diagnosing a co-occurring mental health disorder when there's ongoing substance use. But even if it is substance-induced mood disorder versus a primary mood disorder, the medication intervention for this is not going to change. And if there is continued substance use, like I said, we try to prioritize safety and continued engagement in treatment. So the next question is, have you experienced any stigma associated with MOUD treatment in youth when working with families in your clinic? And what do you recommend any education for hospital providers who do not have addiction medicine background? So by the time a patient and family comes to our clinic, many of the times the patients and families have tried to stop using fentanyl on their own, and there's been a lot of complications stemming from that. So when they come and see me, there's a high rate of acceptance of MOUD. So of the 24 patients that we chose, 21 of them chose MOUD, and one patient came back in a couple of weeks and did decide to go on MOUD. So there was about 22 patients out of 24 just last year. But that doesn't mean there's no stigma. I often find that stigma comes from both the patients, but it also comes from other healthcare providers. I've had one or two patients who were started on Suboxone while in the hospital, and then they were discharged back to their primary care provider, or even like psychiatrists who have said, oh, Suboxone is addictive, or buprenorphine naloxone is addictive, and that you should not be on it. So stigma comes in many shapes and forms, but overall acceptance rates for us has been high for MOUD. And education for hospital providers who do not have addiction medicine background. I know Dr. Henry Jones shared the PCSS curriculum, which is ongoing. Dr. Dan Smith, I don't know if he's listening today, but they do have a project ECHO that was coming out of Mary Center. They would meet once a month to discuss complicated cases in the district. And I will talk a little bit more about other sources of education soon. And what do you believe the role of telemedicine is in treatment of OUD, if any, at this point in treatment innovation? Again, it's all about reducing barriers. We do prefer that we see the patients in the clinic, but if that presents a barrier and prevents them from engaging care, and that means that this patient will not get any care, we always offer telemedicine. And we are not yet thinking about expanding services. We are increasing our volume capacity slowly, but telemedicine is going to play a big role overall in terms of treatment, especially as we think about keeping kids in a recovery-oriented environment, making sure that they go to school or stay in school and they engage in other activities. We don't want their engagement in treatment to be a barrier in their ability to also live their adolescent teenage lives the way they're supposed to. Those are great questions overall. So I'm going to move on just for the sake of time. So the next piece of information I did want to share was also the whole thing with challenge with medication adherence in this population. I did mention that overall, use of injectables, this includes Vivitrol, the buprenorphine injection, Sublocade, and Brixadi, they're all off-label in patients younger than 18. But off-label use is very common, especially since buprenorphine is approved ages 16 and above. This is often due to the lack of safety efficacy data for these injectables in patients younger than 18. Now, a lot of our patients, by the time we consider injectables, it means that they have really struggling with buprenorphine or naltrexone, taking it daily. And there are other challenges which prevents them from, successfully engaging in care, and there's ongoing fentanyl use. So we have about 9 patients now. This was a chart that is we are still submitting for a publication, but as of today, we have about 9 patients, 7 of them on Sublocade and 2 on Brixadi, which is the newer injectable form of buprenorphine. So what we found is that if you look at my retention rates for sublingual or oral buprenorphine, it was 58% at 3 months, but our patients on the injectable are doing great. They're some of the patients were doing the best overall. We just had one patient who dropped out after 3 injections, but the patient also had other challenges, including traveling like 2 hours each way to even access the clinic. And we couldn't, this is a place where telemedicine would not have helped. So overall, it's well tolerated. The patients are retained in treatment. We haven't seen any adverse effects from being on the medication itself. And some of the questions that we don't have answers to is how do we get the kids off of the injection? Because one of the things that we try to answer is when is it okay for adolescents to come off of MOUD? And we don't have answers for that. So we played, it's a shared decision making with the patient and families. At the time that they feel they're ready to stop the injection, we will work with them to successfully, or we'll work with them to stop the injection and see what happens. One of our first patients who has been on it since he was 15, he just turned 17. We just decided to stop for him, and we're going to closely monitor to see how he's going to be doing. So this is our work so far with the use of injectables in the district. So I'm going to finish the slides before we go back to the Q&A. So what we have noticed is that we built the pieces that is required by the hospital and the providers in the hospital to kind of start managing SUDs, specifically opioid use disorder, right? This includes the protocols, the pathways and guidelines in our EMRs, the tools, the medications, the lab testing and all of that. But it's challenging to kind of address that gap in experience and knowledge. So what we did do was earlier this year, we created a task force. We call it the Pediatric Opioid Use Disorder Task Force, especially to look at implementation. How do we successfully utilize the tools that we have built in the hospital to provide appropriate care for our kids? So this task force consists of members from psychiatry, adolescent medicine, hospital medicine, emergency medicine, lab, child and adolescent protection center, our pediatric house staff, pharmacy team, nursing, social work, and media relations. And we meet every 2 months to review the data, identify areas to work on improving care, and implement our plans into action. So in terms of education, it's a huge gap in training for the pediatric workforce. One of the initial things that I used to hear 2 years ago was, "Oh, we are a pediatric hospital. We don't, as default, it's like, oh, we don't do substance use disorders," which kind of was like has completely changed 360 now. But right, like we saw earlier today, and I'm going to emphasize this again. Most substance use disorders, people with substance use disorders initiated use of substance prior to age 18, and we are at a situation right now where many of them are turning to us for care. So we got to address that gap in training. So the addiction program, our outpatient clinic, is a clinical rotation site. So all the pediatric residents and child and adolescent psychiatry fellows at Children's have an opportunity to rotate and see firsthand the clinical work and learn. We have a focused didactic curriculum on increasing their knowledge about substances. And at the end of the day, most of the physicians, the providers, and the trainees, they're all adult learners. So we wanted to make sure that we provide them resources to continue learning and also just keep it all in one place. So one of the nice things was we have a trainee, is one of our child psychiatry fellows, Dr. James Lockhart. He won the prestigious NIDA ACAP Mentor Facilitating Training Award, and it's focused on disseminating substance use related information to our providers. So we have a very simple project in place. Everyone has like a badge buddy t-shirt, mouse pad, or whatnot with a QR code. And this will take them to an intranet page within Children's, which is called Youth Recovery Hub. And this will have all the information they need to screen, do brief intervention, resources in the district for referral to treatment, what harm reduction looks like, and other educational resources for all substances. So this has been our, and this is like, the page is built, we are actively in the implementation phase of this project. And finally, initiating treatment at point of first contact with health system is going to be key. We have projects underway to do that in our emergency room setting with universal screening. We want to be distributing nasal naloxone at that point and connecting with our peer recovery support specialists. We want to decrease time from the first contact to consultation with the specialist. And we are working on ways to make that happen. And finally, building relationships with community providers to create a care continuum, because we can't be the only system providing this care, but we want any point of contact that the child touches in terms of healthcare providers in the region, we want them to be able to successfully address this. And also figuring out ways to engage kids outside healthcare settings. So historically, kids would have never been the population who are like, I have a problem, I need help, and they're going to walk in. So we need to find ways to engage them in community spaces, in schools, and other activities that kids are more likely to engage in outside the healthcare settings. So takeaways, I would say from today is addiction is a chronic disease. Early identification and treatment can significantly change developmental trajectory. The thing about the opioid use disorder in the last 2-3 years has been, for many of these kids, fentanyl is the first and only opioid that they've ever used. And most of the evidence base that we have for opioid use disorder treatment in kids was based on data from a time when there was no fentanyl. And we don't know how these kids are going to look 10, 20 years down the line. And I think there needs to be robust data collection informing us on the care we are providing and how to adapt based on the needs. Few patients younger than 18 are offered MOUD, and we need to change that. And like I said, buprenorphine is FDA approved ages 16 and above. And finally, as pediatric systems, we need to learn and adapt quickly to meet the needs of adolescents with opioid use disorder. Finally, I just wanted to thank our psychiatry division at Children's, their chief, Dr. Rob, our adolescent medicine division, and chief, Dr. Abraham, and Dr. Schottenfeld, and the rest of the psychiatry department and the addiction medicine fellowship at Howard, Dr. Dan Smith at Mary Center, my research team at Children's and Howard, and finally the DC Hospital Association, the DC Department of Behavioral Health for all your support.